So thank you very much for the introduction and also for the invitation. So my name is Anselm. I'm currently doing MD PhD under Professor Christoph Gönig in the field of cardiology at the Inselspital in Bern, Switzerland. And today I would like to present to you application of patient-specific computational fluid dynamics in anomalous aortic origin of a coronary artery. So the general structure will be that I will shortly give an introduction about the clinical problem. Then I will talk about the systematic review we did to assess what currently is out there as evidence. And in the end, I will present our current project. So anomalous aortic origin of the coronary artery, or AOCA in short, is an inherited and rare disease. Can you see the mouse? No. Then on the top, you can see a normal anatomy where you have the heart muscle basically, and the right coronary that comes from the right side, and the left that comes from the left side. And if you focus now on the image below, you can see that the right coronary comes from the left side, or it could also be the other way around. The left would leave from the right side. So in military recruits and athletes that died during strenuous activity, this specific anatomy was actually present in 1/3 of all cases. However, this does not represent the risk of people living with AOCA, since in recent years we do a lot more cardiac imaging and the incidence is constantly rising. Patients are more often middle-aged and asymptomatic, so the question is this an incidental finding now, and should still all patients receive an operation? So it's definitely important to look beyond the anatomy and also do functional assessment in these patients. So the most important thing is that the anomalous vessel runs inside of the aortic wall, and I indicated this in red. And the problem is that this part inside of the aortic wall is firstly, it is deformed and elliptical, and I try to demonstrate that when aortic pressure increases, which typically happens during physical exercise, the part inside of the wall gets compressed. So all of the tests we do with our patients focus on first resting conditions, and then we simulate exercise conditions with a drug, and we reassess the patients. So you can see that the heart rate increases between the two tests from around 77 to 150, and the blood pressure from around 114 to 140. And one of the tests we do is actually quite comparable to how we treat myocardial infarction. So we come with a catheter through the artery in the arm, then we go to the heart and we put a little wire inside of the vessel. And on top of this wire, we have attached an ultrasound probe. So we are able to look inside of the vessel when we pull it back and look at the area of the vessel. And then we do this for rest and stress, and we can actually see in this patient example where the area drops from around 8 square millimeters to 4.5 square millimeters. Further, we also measure the pressure drop over this stenosis, which we call fractional flow reserve, or FFR in short. And for the 33 patients we assessed so far, we could see that pressure significantly drops from rest to exercise, and the area decreases significantly from rest to exercise, therefore proving this lateral compression. And additionally, you can see with the red dotted line, the values below, so only a small part are actually hemodynamically relevant and need operation. So this is still a very expensive and uncomfortable procedure for the patient. And here, computational fluid dynamics or fluid-solid interaction models could be a valuable alternative to predict flow in these patients. So first, we did a literature review to assess what has already been done. 19 studies were included in the final analysis, and we split them into dedicated CFD models and general-purpose CFD models. And what we meant with dedicated CFD models is there is software out there which can predict the FFR, so the pressure drop, based on CT images, but the only user input allowed in this software is basically doing the segmentation of the geometry. Otherwise, you can't touch anything of the simulation. So 12 studies use this approach, and 5 case reports actually validate their results with invasive measurements. And it's a small sample size, but the results were not significantly different. However, this definitely cannot show this lateral compression, so the model is unable to do that. So the general purpose CFD models basically included every other approach to build a CFD model. And we compared them based on a standard workflow for CFD. So first we need to create some kind of geometry based on patient images. Here I would mainly like to focus on the image modality used. Then a mesh is created on which boundary conditions are applied. Here I want to say something quickly about mesh optimization, blood parameters, and then CFD or FSI, and a quick note on microvascular resistance. And then the actual flow is calculated with the use of a specific software. And from these obtained results, the desired parameters can then be extracted. So basically pressure, voltage, stress, which then should be validated against some kind of clinical data. So 7 papers use this general approach and 6 use the CCTA. So it's a CT just for the coronaries. And 1 group used CMR, so that's MRI, but for the heart. And here I want to stress that the image resolution is actually crucial, since this is a very fine structure with a small area. And I wanted to demonstrate here how the image resolution of the image modality influences the geometry. And on the left side, you can also see a shell created from the ultrasound images on top, where we can also show the heartbeats. And on the bottom, we have the CT images in the same patient. For mesh, not much was reported, and mesh-independent studies were only performed in 4 of the studies. And for blood rheology, mostly a Newtonian model was used, even though blood is non-Newtonian fluid. And this is valid for normal coronary simulations. However, if this can be applied in anomalous patients is so far not known. And one thing I really want to stress here again is that 4 papers didn't do any exercise condition testing, but in all of these patients, these anomalies only can become relevant during exercise. There are no cases where there is a problem during rest. So one group actually brought everything together, and they already built an FSI model. So let's see why the video is not working yet, where they actually did the interaction between the aorta and the coronary, and they did that for rest and for stress conditions. Real quick note on the outlets. The microvasculature is actually very important for the hemodynamics, but we can't image that. It's very small, but you can see here on the left side, on the bottom, you see the flow for left coronary, and on top for right coronary, and the dark blue shows when the heart contracts. And when the heart contracts, the microvasculature also gets compressed, and the resistance increases a lot, so we have a changing resistance basically over 1 cardiac cycle. For post-processing and validation, actually only 1 paper compared the results to invasive measurements, while all the other ones used voltage stress and vorticity magnitude, which can't be directly compared to clinical data. And the same FSI model I showed you before, they validated their data, and you can see with the blue dots that for resting condition, the model worked quite well. But as soon as we went into the exercise condition, which is important, as I stressed before, the variability increases a lot. So in conclusion, I think we can say that currently no model can predict hemodynamic behavior in these AOCA patients. And this is especially true for this lateral compression during these exercise conditions. So what are we currently working on together with SimQ? So first we built a CFD model that should predict the FFR adenosine, which is basically the pressure drop in rest without the lateral compression. And except for the geometry creation, we have a fully automated workflow there. We can do static or transient simulations for either coronary or aortic root together with coronaries. And the focus here was really to get a fast simulation, which is not computationally expensive. However, this definitely cannot show the lateral compression since we still used rigid walls in this first one. What we have to do still is compare the pressure results from our simulations to our invasively measured pressure results. Then the second approach was to just build a finite element method model. So we try to only show the compression of the intramural segment. And for that, we use the mesh, which is a combination of the CT and the ultrasound images. And we want to compare the deformed model basically again with the ultrasound images and find the optimal material properties to correctly model patient-specific aortic tissue. And in the end, we hope to bring everything together and build a fully functional FSI model, which can do both and predict flow for rest and exercise conditions. So we can hopefully provide that for our patients. So thank you for your attention, and I'm looking forward to questions now or later this evening.
We have time for a quick question.
Perfect. Yeah.
Is there any additional risks to putting a stent in that location where the vessel is in the wall of the
I brought a slide for that. That's
Thank you later.
Yeah, very interesting question. There was only one paper published 10 years ago where they stented like 20 of these patients and had a very high restenosis rate. So currently everybody's blocked a little bit, but we started to still do stents in older patients where we don't want to give them an operation. But we had that in 3 patients now, and in 1 we also had already a bit of intimal thickening and restenosis. So I'm not sure if it will actually be feasible. But it would be an interesting topic again for simulations if we have a working model. Yeah.
Just because I don't know, so what is the surgery when stenting is the not as invasive method? So
Brought another slide. I thought that people would be interested in that. So it's a smaller operation than for standard heart surgery, but it's still open chest surgery, not the full big cut. And then you have to open the aorta from the front, not fully, but still heart has to be stopped. And then the part inside of the wall, which makes problems, is basically just slit open, and these 2 flaps are attached on top and on bottom. So this is like the most used operation. There are some different operations, but this is the most.
it gives more room for the
Yes, and the vessel gets round again when it leaves the aortic wall and is basically normal again. So we just don't want this compression anymore.
Okay, thank you so much.